Let's talk to an MP opposed to this legislation, Conservative MP for East Wiltshire and Shadow Minister Danny Kruger. Thank you very much for talking to us on Newsnight. Now, you have said that your objections to this bill are not based on your religious beliefs, so do explain what your objections are.
Thank you. Well, I have two objections in broad terms. The first is to the bill itself, the text of the bill. I'm afraid to say, now that we've actually seen it all in black and white, I respect the effort that Kim and others have gone to draw a bill that is safe, but unfortunately all the safeguards don't work. There's nothing to stop people, sad to say, slipping through the cracks of this bill. There's a whole lot of categories of people, I'm afraid, who would fall in scope, and I can talk more about those. But the second objection is to the more general effect that the bill would have on the relationship between doctors and their patients, and indeed our whole relationship with the state. If we decide that it's acceptable for government officials, people licensed by the state, doctors, to conclude that some people are better off dead, our whole understanding of the responsibility of care that the state and the NHS has to us is changed.
But this bill is not about medical professionals concluding who would be better off dead. It's about the patient making the decision voluntarily, without pressure, without coercion. They have to be of sound mind, with 6 months or less to live, with a terminal illness that cannot be reversed by treatment.
So those are all, that's the words of the bill, but yes, how do you actually enforce and implement those principles? So the 6-month terminal illness is notoriously impossible to determine. No doctor can say definitely that somebody has 6 months to live, so you would be asking a doctor to determine that it's acceptable to put an end to this person's life.
Well, doctors make that assessment all the time, don't they?
Well, they don't decide to kill people.
No,
they don't decide to authorise a death.
They won't be deciding to kill people. That is scaremongering. It's the individual patient that makes that decision.
Well, what is being required is that you're asking a doctor to give you lethal drugs. That is a decision that the doctor will have.
You're asking a doctor to help you shorten your death.
Well, you say shorten your death. What we're actually doing is shortening life. And I fully respect...
These are people that are dying anyway.
Well, yes, although, as I say, people who have a diagnosis of 6 months to live would be eligible for this procedure, and that is impossible to predict with any accuracy. So, in fact, anybody who decided that they wanted to end their lives could theoretically qualify for this, as happens in other jurisdictions. So somebody with an eating disorder could decide that they're going to stop eating. They could find a doctor
Not true.
Absolutely true.
Not true.
Victoria.
Anorexia is a mental health condition.
Yes.
And that is not allowed in this bill.
However, a physical condition that is consequent on your mental health condition would be allowed in this bill. So if you are physically ill because of your mental health condition, you would qualify. So as happens everywhere else, if you decide that you're going to refuse treatment or refuse food...
I'm sorry to interrupt. I do think that is wrong.
Well,
because this is about terminally ill people whose treatment cannot be, whose condition cannot be reversed by treatment.
Yes, and you now have people being diagnosed with what is called terminal anorexia. So people with eating disorders who doctors conclude are going to die are being put on palliative care pathways here in the UK at the moment. So as happens in other countries which have laws like this, it is perfectly possible for people with eating disorders to qualify for an assisted death. That would happen under this law, even though it's not what they intend. And this is an important point, because I do respect the intention of the drafters of the bill. The problem is the implications. You can't write in black and white a law that is safe, that won't be progressively loosened and that won't be abused. And as I say, the real danger of it...
There's no reason to think why it would be progressively loosened. That would be down to Parliament.
Well, in every single jurisdiction where an assisted dying law is in force, the criteria, the eligibility, the access to it have widened.
Not true.
Yes,
not true.
Again, true.
Oregon,
in Oregon, the conditions of the eligibility and the access in Oregon have been widened.
No, they haven't.
Yes, they have. The time it takes that you have a waiting period has been extended in Oregon. Also in Oregon, the data is so poor that we never actually know who's really getting the treatment there.
But it has stayed since 1997 for people with a terminal illness.
Well, as I say, also people in Oregon with conditions that you or I would not regard as terminal, including eating disorders, including diabetes, have qualified for an assisted death in Oregon.
But not under the terms of this bill.
Well, I was pointing out that in every jurisdiction where any bill like this is on the statute book, it gets widened. Because think about what we'd be doing. We'd be saying that some people have this new human right, but some people don't. So every so-called safeguard would very quickly become a basis of a discrimination claim, especially under our human rights law.
No. What you're thinking about is Canada, where it definitely has been widened. The scope has been widened because the courts there enforce broad eligibility criteria derived from Canada's existing Charter of Rights and Freedoms.
Yes.
We don't have that here.
Well, we have the European Convention of Human Rights, which would very quickly be deployed to insist that some people who have this right...
It's still a matter for Parliament, though, if it was to be widened.
Not under the ECHR. That's one issue with the ECHR. It enables the courts to challenge Parliament and say that actually you're discriminating against a particular group. So I fear that this bill would be immediately widened. But listen, even if it weren't, as I say, there are loopholes in it as it currently stands. And anybody, even within the criteria of the bill, who is frail, disabled, close to the end of their life, would be obliged to have this conversation.
No.
To think, yes, they would be.
There's no obligation to have the conversation.
No, they would be obliged to think about it. We'd be putting on to every single frail and elderly and dying patient this choice. And this choice, by the way, which again, proof from elsewhere demonstrates, reduces the proportion of end-of-life spending that goes on to palliative care. So we'd end up actually reducing the real choice that we should be giving to the dying, which is a genuine choice of proper, decent, high-quality palliative care, which everybody should get. We'd be reducing that for...
Not necessarily.
Well, not necessarily, but almost certainly in practice, because again, around the world, in every country, the proportion of end-of-life spending that goes on palliative care reduces when you introduce this choice, which, by the way, is of course the right choice for if you think about the economics of healthcare. It's cheaper, it's easier, you stop bed blocking. So the
can I just to say, Palliative Care Australia had a look at the provision of palliative care in Oregon, Washington State, Canada, Quebec Province, the Netherlands, Belgium. Their report in 2018 concluded there was no evidence to suggest that palliative care sectors were adversely impacted by the introduction of the legislation. If anything, they said, the jurisdictions where assisted dying was available, the palliative care sector further advanced.
Well, palliative care around the world is increasing because we're getting older. So every country is increasing investment in palliative care. But the countries with assisted dying laws are increasing it less than the countries without it because the investment is diverted into this option. So that is why the idea of increasing choice, which people want to do through this bill, and I fully understand and support the idea that people should have as much control over the end of their life as possible, actually we'd be reducing the choices that people have. The real choice people should have is high quality palliative care for all. And I'm afraid to say all this effort and potentially money that we're putting into this idea and this whole debate really should be going into the real priority, which everybody agrees is what's needed, which is investment in our palliative care system.
What about patients who are in real pain, who are going to die, who are dying, and even with the best palliative care, it's not always possible to control the pain.
Yeah.
What would be wrong with giving them autonomy and independence over the manner of their death?
I have no principled objection to that. If we could phrase a law adequately that didn't have all of these dangers that I've described, that wasn't inherently open to mission creep and to a widening scope, then I would understand the case for making a law that would apply just to those people. I'm afraid we can't. And what I would say is actually the evidence is increasingly, thanks to the advances that are being made in our palliative care sector, which would be denuded of support if we went down this road.
Not necessarily. Well, you keep saying that.
Well, I'm afraid
not necessarily at all.
Well,
you might be right, you might be wrong.
Let's hope it wouldn't happen here because it's happened everywhere else. But yes, fine.
I've just given you the evidence from Palliative Care Australia.
Well, yes, so we can dispute that. I do dispute that. The point is that if we were to go down this road, the real focus we should be making, which is ensuring those people you just described end their lives well. And with advances that have been made in recent decades in analgesic science, in the science of pain relief, it is really possible to get on top of pain for almost everybody. And I'm not going to say that...
Let me give you a quote, if I may. Yeah. Dr Matthew Doré from the Association for Palliative Medicine of Great Britain and Ireland told the Health and Social Care Committee report into assisted dying, which was published in February this year, that palliative care cannot eliminate all suffering or all symptoms.
I'm afraid it can't. That's right.
Right. No. So you accept that?
I do accept
So what would be wrong with somebody in that situation making a decision about the manner of their death?
Well, the implication, I think, of your question, if you're basing it on that quote, is that we should take steps to eliminate all suffering, and I don't think we ever can.
Okay.
We can't eliminate the existential suffering, the emotional distress that people feel. That needs real treatment and support. we can get on top of physical pain. Increasingly, we really can. And I think we should be investing in a system which supports people to die well, not to give them this terrible option, which, as I say, imposes an obligation on their families to think about doing this,
Okay.
rather than ensuring that they die well.
Thank you very much. Thank you, Danny Kruger.